Dr. Rohit, would you like to introduce the next speaker?
So, pleasure to have introduce the next speaker, Dr. D. Ramamurthy from the Eye Foundation, Coimbatore, an outstanding speaker and whose clear, lucid presentations, particularly on biometry, are much sought after. So, he'll be talking on optical and immersion biometry in cataract. Dr. Ramamurthy.
Thank you, Rajesh, and thanks ARC for this kind invitation. I'll be essentially, for reasons of time, covering on aspects of optical biometry. Refractive cataract surgery has become the mantra today, and though significant advances have been made in intraocular lens technology as well as extractive technology as far as phacoemulsification machines are concerned, it's a classical case of garbage in and garbage out. So getting your measurements right is extremely important, and that's where optical biometry comes to play a very important role. As far as this presentation is concerned, I have no financial disclosure. There are three types of optical biometers I'm conversant with, which we are using in our different centers, the IOL Master 500, 900, and 700. I must also say that we are spoiled for choice today. There are several other excellent biometers that are available, and you have to pick and choose. Many of them have the modern intraocular lens formula incorporated in them, very good features. So if at all you are looking for purchasing one of these, you need to do a significant amount of research before coming on to what exactly you want to work with. My experience have been largely with IOL Master 500 initially, which was based upon A Scan biometer, and it was the first optical biometer that became available. Today, almost we are completely shifted over to the IOL Master 700, which is based upon the Swepsos OCT, and it's essentially a series of B Scan biometers. Biometry that's taking place. There are more than 2,000 scans per second that's measured with the Swepsos OCT, and the scanning is done at 0 degrees, 30 degrees, 60 degrees, 90, 120, 150. So it gives a multi-dimensional view of the entire eye, right from the corneal epithelium to the retinal pigment epithelium, and this is essentially analyzed by the software in the instrument to give us all the data that's required. One of the major differences between the IOL Master 500 and 700, and the 700 shares these features along with the Lenstar 900, is that it gives information about both the corneal thickness and the lens thickness. And this essentially becomes important when you're dealing with the latest generation formula like the Barrett or the Bailey or even the Holiday 2, where 7 or 5 different features are required compared to the earlier regression formula that we used to use. So essentially, that's the reason that these biometers work very well integrated with these modern generation formula. Because of the Swepsos OCT and the B-scan biometry, which is integrated, both the corneal measurement as well as the lens thickness is something that's reliably reproduced by these two instruments. We look a little deeply into these features. When it was the IOL Master 500, here again, the patient had to look directly at the red light, and that's the reason that we thought that it is most often concentrated on the visual axis. But in case the patient looks away, then the instrument measures a different part of the eye, and there was no objective way of checking whether the patient is focusing on through the fovea or is looking away at the time of taking the measurement. On the other hand, with the IOL Master 700, you have the fixation check or the retina scan, and basically we make sure that when the patient, at the point of measurement, the light is falling on the foveal pit. In case it is not on the foveal pit, then you know that it's going to be inaccurate measurement. Just to illustrate this point with a couple of examples, you see two measurements which both are being taken at the foveal pit exactly where it should be ideally done. So this translates into very just a 0.02 diopters of difference in the keratometry. And as far as the axial length is concerned, again, you find that it's just about a 10 micron difference. And that's the reason that you'd find that when it comes to intraocular lens power calculation, two subsequent measures almost give you exactly the spherical power and cylindrical error. And that's the reason that having this ability to objectively cross-check whether the patient is focusing rightly is an extremely important feature with the IOL Master 700. When it's not so, as you can see in this case, you do not see the foveal impression. It's poor fixation of the patient, which can be detected by the examiner. And you see that there's almost a 0.5 diopter of difference in the keratometry and 190 micron difference in the axial length. And obviously, it translates to a error of almost a diopter as far as the spherical power is concerned, and again about a 0.5 diopters as far as the cylindrical error is concerned. So because we are able to objectively verify whether the fixation is on the fovea, it ensures that the intraocular lens power calculation is quite accurate. It also acts as an OCT as far as the posterior in the area of the macula is concerned. A feature like a macular hole, a dry RMD, you can see some drusenoids over here, a diabetic maculopathy, epiretinal membrane where you see sharp image right in front of the pigment epithelium. Obviously, this is not a replacement for a conventional OCT that our retina colleagues use, but it tells you immediately, this forewarns you that something is wrong with the retina, and maybe a retinal consult is extremely important before going ahead with the surgery in these cases, so as to avoid the suboptimal outcome in the postoperative period. There was no significant instrument that was available to us as far as the AC depth was concerned in the postoperative period. But here you can see this is with the lens and this is with the pseudophakic lens, and you can see the precision with which the AC depth as well as the effective lens position can be measured with this particular instrument. It also gives us an idea about the lens tilt. Most often, both the natural lens as well as the pseudophakic lens that we place is tilted a little nasally. And this is supposed to have an impact as far as the astigmatic outcome is concerned. And work is on to incorporate this as far as the exact orientation of our intraocular lenses is concerned in the toric intraocular lenses. This is work in progress, but suffice it to say that if a significant tilt is noticed, then these cases may be ruled out for premium intraocular lenses. This is a study which showed that with the IOL Master 700, the repeatability of axial length measurements is in the range of about just 9 microns. And with the IOL Masters 500, it's 500 microns. With LensStar, it's going ranges between 20 to 35 microns, which is almost 1/10 of the error that you could get with the Immersion A Scan. And that's the reason that these instruments work very accurately. And another important feature, because of the Swepsos OCT feature with the IOL Master 700, almost the densest of cataract, whether it's a posterior subcapsular cataract or a total cataract that you see over here, or even a posterior polar cataract, even a mild vitreous hemorrhage, you are able to get a good repeatable IOL power measurement, which was essentially not possible with some of the earlier instruments. Even with the IOL Master 500, it used to be that about 28% of the cases you're not able to get a reliable measurement, and so you had to resort to Immersion A Scan, which is again well handled, gives you fairly reliable measurements. As far as the keratometry is concerned, which is again an important feature because of which axial length and the IOL power calculation could go wrong. There were just about 6 points that was measured with the IOL Master 500. With the LensStar, it was 32 points. But with the 3-zone keratometry that's incorporated with the IOL Master 700, these are 18 points that are measured at 1.5 millimeter, 2.5 millimeter, and 3.5 millimeter. And this gives you an excellent idea about the keratometry. And I find that I have virtually given up doing an auto K or a manual keratometry in these cases and go by the keratometry readings that are given by this particular instrument. The telecentric keratometry is again an important feature. What exactly do you mean by that? Is that the patient could be a little uncooperative, could be moving his head backward or forward. The technician may not be absolutely experienced, because of which the spots of light that you see may not be exactly in focus, but the distance between these spots do not vary, because of which, irrespective of the device to eye distance, the keratometry readings that you get are extremely precise and repeatable, and that's an extremely important feature as far as telecentric keratometry is concerned. The we all know from our knowledge of toric intraocular lenses, especially, that the posterior corneal curvature measurement is extremely important. It was possible, it's in scientific image instruments like the Galilei or the Pentacam, but it was found that it was not totally correlated with the toric intraocular lenses with the formula like with the Barrett or the Baylor. Now with the IOL Master 700, because of the OCT principles, you are able to measure the anterior corneal curvature very precisely, and then get an idea of the corneal thickness, because of which you are able to exactly arrive at the posterior corneal curvature, and because of which you get a posterior torus fit, which is incorporated in the formula that is available for the intraocular lens power calculation. That's the reason that the IOL Master 700 gives you all these readings. That is the keratometry, which is essentially from the anterior cornea, the posterior keratometry, and the total keratometry, which incorporates values of both these. And these are the intraocular lens power calculations based just upon keratometry or the total keratometry. Sometimes they correlate, but sometimes, as you see in this case, there's almost a 0.5 diopter difference. This is not just in the toric measurement of the toricity, but even, as you can see in this case, even in the spherical power calculation, there could be a difference. More importantly, it does not require any big change as far as your intraocular lens power calculation is concerned. You could incorporate the measurement that is taken with a conventional modern generation formula that you're kind of normally using, or even the ULIP constants, and then go ahead with your intraocular lens power calculation. And again, specific formula that are used with this IOL Master 700 has become available. Now the Barrett comes with the Barrett TK Universal 2, which is essentially used for the calculation of the spherical intraocular lens, and the Barrett TK Toric for the toric intraocular lens power as well as this orientation. Now we have also the Barrett True K Toric formula, which is essentially used for the intraocular lens power after a post-refractive surgery scenario. Because of the exact measurement of the anterior curvature and the posterior curvature, the specificity as well as the precision of these formulas is significantly enhanced. Whether it's the Haggis or the Barrett that's used, incorporating the actual measurement of the posterior corneal curvature, whether you have a cutoff of a 0.5 diopters or a 0.75 diopters or a 1 diopter difference in the toric IOL power calculation, you find there is a significant improvement when you actually measure compared to what is mathematically assumed in the older Barrett formula. And again, we all know that when it comes to post-refractive surgery scenario, because of the change in the alignment between the anterior corneal curvature and the posterior corneal curvature, it becomes quite a challenge. Today, because of the precise measurement of the posterior corneal curvature, these studies which have just come out in the April 2020 issue has shown that the measurement, the accuracy of the intraocular lens power calculation, especially for toric intraocular lenses, becomes significantly enhanced. With the availability of the IOL Master 700, our very workflow has changed in the sense today, once the patient goes in for a cataract surgery, the first measurement that we do is a toric measurement using this formula. And when we see the TK is about 1.26 diopter, then automatically, whether the patient is opting for a monofocal or a multifocal, the conversation shifts towards a toric monofocal or a toric multifocal so as to achieve emmetropia for all distances. Again, this instrument also gives you an idea about angle alpha and angle kappa. Angle alpha is relatively more important when it comes to intraocular lens implantation. When anything beyond 0.5 millimeters, we tend to keep away from premium intraocular lenses. This value has become a little questionable of late. I personally keep the cutoff value as 0.7 millimeters. Angle kappa is more useful as far as keratorefractive surgery is concerned, because here you are measuring the difference between the center of the pupil and the visual axis, while your intraocular lenses are more aligned depending on the limbus, and that's the reason the angle alpha is more important. So along with improvement in intraocular lens technology and the ability to extract intraocular lenses using the lasers as well as modern phacoemulsification systems, today we have excellent imaging systems incorporating the latest generation intraocular lens power calculations. so that it's a possibility to achieve emmetropia almost in 90 to 92% of the cases, irrespective of the power that you are dealing with or whether it's a post-refractive surgery scenario. Thank you so much for your kind attention.
Thank you very much for a very lucid talk, Dr. Ramamurthy. I have just one question to ask. Now that we know that where we stand with IOL Master 700, would you say that immersion biometry needs to be put away into a dustbin, or with the newer formulas which we have, if you incorporate it, would it work nearly as well?
Absolutely. I think having Immersion A Scan is absolutely necessary. And as you know, among our centers, there are a few centers which still do Immersion A Scan, do multifocal intraocular lenses, toric intraocular lenses with good results. The only difference between an Immersion A Scan and a good optical biometer, I feel, is the optical biometer is relatively idiot-proof, in the sense that you could have a reasonably inexperienced technician or a patient who is not very cooperative and maybe a post-refractive surgery scenario, etc., and still get reliable data. But as far as if an immersion A scan is done by an experienced technician using all the right modalities, then it's possible to get quite good repeatable axial length as well as the keratometry readings. And again, they can go on to the APACRS, AACRS websites and get the benefit of the modern formula like the Barrett Formula for their intraocular lens power calculation. So definitely, if you can afford it, a modern biometer like the IOL Master 700 or the LensStar or something equivalent to that is good. In case you are thinking of upgrading to a better phaco machine, I would say that buying a biometer first before going on to upgrading your phaco machine, because with phaco emulsification, I strongly believe that technique is more important than technology itself. But if you don't have it, if you do immersion A scan well, you can again get very good results, and we are experiencing it in our own centers.
Sir, I have a question. Sir, for example, if you don't have access to IOL 700 and you can't calculate the posterior corneal astigmatism, and you opt for the option of the predicted posterior corneal astigmatism in the IOL power calculation formula, so is it okay, or should we, just don't even include the posterior corneal astigmatism?
Absolutely. The thing is, the basic Barrett formula mathematically calculates and assumes a certain posterior corneal curvature based upon the anterior corneal measurement. So if you're not measuring it, you directly go on to Barrett Universal 2 or Barrett TK or Barrett 2 TK and go ahead and do the calculations. And it's only when you are actually measuring using something like IOL Master 700 when the TK variant comes in. So you cannot combine both. You cannot measure it and again use a formula which mathematically assumes a posterior corneal curvature. So you have to pick and choose whether you are going to use the simple Barrett formula or the Barrett TK formula, depending upon which biometer that you are using.
And one more question, sir, that if you are using these like IOL Masters or LensStar, so then the role of keratometry, or, if we were talking about topography, that's totally out. We don't need to do any K. We'll just rely on the keratometry readings which have come from the biometer.
Almost 4 to 5 years, till about 3 to 4 years, I used to love my a manual keratometer. That was the case almost for 3 decades. But today, I believe the technology is progressed to an extent where your optical keratometers, good auto keratometers, give you extremely reliable readings, and definitely I would any day go by them than a manual keratometer.
Ram, one question.
Yes,
Sorry,
yes.
one question, Ram. We always talk about the main two companies, and that is the IOL Master and the LensStar. But for a normal person, where there is a cost, because today if you look at an IOL Master 700, that's 30, 35 plus or whatever it is, and the advanced version of LensStar is also 20 to 25 or whatever it is. There are other companies who also provide, for example, you have the Aladdin, you have the Nidec, you have the Tomy, etc. So from a common practitioner's perspective, I fully agree with you that the immersion is very much there and you still will need it, and it's a good thing. And even when you're using a IOL Master 700 with the swept source, you are still having some patients where you can't get the axial lens, so you will still be needing that. So what I am asking is, if we compare with these other biometers that are available, and now recently I'm looking at one OCT angio from Hewitts, which by just an addition of 1 lakh rupees, they will also give you the biometer. Because after all, if you look at it, it is the measurement when you're doing the OCT, you're going to the retina and then it's coming back, so you can measure from there. The only thing is so the second part is the formulas. Just leave the formulas apart. But the measurements that you get on the other ones, how accurate are they, or would they suffice in say 95%, 99% of the cases for private practitioner, or he still needs to go for these upper end biometers?
I cannot agree more with you, Maipal. Actually, this was my opening statement in the sense that, my experience with IOL Master 700, 500 and Lenstar, but there are other good equipments available and you definitely need to look into it. We ourselves have two more recently bought two Tommy biometers, and I think all these are good instruments. The top one itself has the Barrett, and even, leave alone, even the formula is incorporated in many of these biometers. And they're also quite precise. It's definitely having a look at them. So I was talking from my personal experience, but it's extremely important that cost is a consideration, and IOL Master 700 definitely is beyond the reach of many. So that does not mean that they do not go on to an optical biometer. And there are other excellent alternatives available, incorporating the modern formula also. And and many of them would even give you a demo. You can keep them for 10-15 days in your center, test it out, and then talk to others like Maipal who have experience with their instruments. I definitely do not recommend that these are the only instruments you go with. It's good that we have the freedom of choice and the ability to pick and choose what we need.
Yeah, because I have the experience personally. Personally means in our centers of the Tommy plus the NIDEC, and I have not had any complaints from those centers where we have kept them. So it's worth, as you were saying, it's worth the individuals trying that out, because the costings are reasonably different between the two. Yes, the angle measurement, alpha, kappa, etc. How much of value that is, that one has to see. But I think that's the point that I wanted to make, that there are alternatives to the best.
I think one other important thing is each of us have to spend time to understand the capability of our equipments, whether it's a pentacam or a biometer or anything, or even a Varion. When you start preparing for a talk, you really realize the capabilities of these machines. Very often it's a optometrist who has taken the readings and you just go by it. But then when you do a deep dive into it, you find that so much is available, and most of these equipments will give you fairly reliable readings. I think it's important that we spend time understanding them.
Yes.
Murli, you have anything to ask, or shall we move on to the next speaker?
I have one question, sir, for the PGs. What is different in the IOL Master 700 that it is able to do axial length measurements in dense cataracts, whereas other biometers are unable to penetrate?
I think it's a penetration.
Basically, you tend to think that IOL Master 700 is just an upgrade over IOL Master 500. Actually, these are two completely different instruments. This uses a swept source OCT, while that is based upon different principles, and even the Lenstar uses optical low coherence reflectometry. All these are, and IOL Master 500 uses the PCI, partial coherence interferometry. So because of the swept source OCT, this gives us the ability, for example, since you asked me, why is it called swept source? Because the average wavelength is supposed to be 1060 nanometers, but it's varying between 1050 to 1070 nanometers. I don't really understand the exact physical principles. It is because of this capability that it is able to penetrate through almost 98% of the media and give you a fairly reliable readings.
The technology is different.
Yeah.
Thank you.